denied for that referral to the psychiatric facility. Mr. Chairman, there is an amendment that Sarah has.
Three line amendments. Your first line amendment is going to be on, all three amendments are on page 3. The first amendment is on line 134. After hospital that provides, insert inpatient. The next amendment will be on line 135. After requires, comma, strike prior to refusing the admission of, and insert for any refusal to admit. And the final amendment is on line 137. After physician, there at the beginning of the line, insert comma if requested by such referring physician, comma.
Okay. You want to explain those?
Yes, Mr. Chairman. Overall, first, if you don't mind, I'll just explain the bill.
Sure, thank you.
I think the amendments are just clarifying on the original language as drafted. What we will see not infrequently is that in an emergency room, a patient we brought into the emergency room needs to have a psychiatric admission. That patient may also come in with some medical conditions that need treated. The emergency room physician will treat those medical conditions, and yet the psychiatric condition remains. They'll try to find placement for that individual and often run into a brick wall. And some of the facilities that are receiving of these patients will not even allow the physician on call to talk to the emergency room physician. The admissions are actually blocked by administrative personnel that simply say, no, we're not taking that patient, even though there is room at that facility to take and accept the patient. In other circumstances, we've had where folks who are not licensed to practice medicine in the state are demanding that medical physicians perform certain tests, lab tests, radiology tests on a patient that are not indicated before that patient is admitted to their facility. What this language does is it says that if you are denied admission of a patient, or at the request of the physician who wants to transfer that patient, if they want to speak to the doctor at the receiving locality, they must be allowed to speak to the physician. You cannot block a physician-to-physician communication. This is already in the medical screening and medical assessment guidance from the Virginia Department of Behavioral Health and Development Services, but it's guidance. There is no teeth to it. There's no way to actually enforce it, and it is frequently ignored. This codifies what should be common practice.
All right, thank you for that explanation. Shall we adopt those line amendments?
Second.
All right, all in favor? Dr. Garrett.
Thank you, Mr. Chairman. So, Dr. Dolly, so you and I both made lots of these referrals. So, help me with this scenario. Someone's acting out bizarre behavior in the community, is taken to the local emergency room, they rule out some sort of substance abuse issue, and that physician, that emergency physician, makes a determination that there's not a medical indication for this, but we think there's some psychiatric. That physician then doesn't take upon his or herself to do that process. That's why we have these community service boards and that work differently across our communities, and I'll grant that. But this language, as I read it now, my inference to this, and help me get a comfort level that I'm wrong, my inference to this is the physician's moved on. The physician's got lots of real medical emergency patients that he or she's going to be taking care of. But now there's an obligation that once the CSB goes through the process of trying to identify a hospital, each one of those hospitals that might not have a bed available, and that's what the CSB person is told, but now there's a statutory duty both to the physician, and Amy, correct me if I've misinterpreted all this, a statutory difference, a duty on the part of the emergency room physician that's already sort of signed off of that patient to now have to have that communication. Help me, give me a Maalox moment.
I hope your Maalox moment is that I wish it worked that way. It doesn't. So in many, many circumstances, the emergency room physician is the one who's actively engaged in trying to find a facility to take these individuals. And in many, many circumstances, that emergency room physician is tied up in this process of spending an enormous amount of time trying to get through barriers that are put up just to talk to a physician at the other end. And many times, they're never allowed to talk to that physician. They can never say out to the physician, no, this patient does not need another MRI before they're transferred to a facility. So we find, and I'm sure the emergency room physicians representative can speak to this, the ED docs don't know a lot. The ED docs are very much engaged in placement issues with these patients and are very frequently have barriers put up in front of them and inhibit their ability to take and place these patients in a rapid manner.
Thank you, Dr. Garrett. Amy Parent-Syward on behalf of the Virginia College of Emergency Physicians, and we do support this bill. And to answer your question, I think Dr. Stoll is right, and the other piece of this is when we are involved, and even if the CSB worker does come and does do that piece of the process, what happens is a lot of times the barriers that are put up at the inpatient facility are medical in nature, meaning they're requiring new tests, they're requiring different labs, they're requiring more scans, and that's the piece where the physician will request to speak to somebody on the other end. And what's been happening, and as Dr. Stoll said, in our guidance document, which we've worked on extensively with the department and VHHA and all the other workers, it does say in there that this is the best practice, that if a referring physician requests to speak to that inpatient facility, that they should be able to talk. It isn't always happening, but it's that piece that really, it's that medical piece when they're requesting a lot more labs that we don't believe is necessary. We want to just talk about why do you think you need that lab? We don't think you need that lab. This person is medically cleared, to use that term. And we've actually been working with the Virginia Hospital Association over this interim to come up with some standards for if people, what kind of tests and things are necessary. So we're trying to come up with some sort of more solid solution. I think this is definitely a piece in that puzzle. So we appreciate this bill. Thank you.
Mr. Chairman, Paul?
Dr. Garrett.
So, Amy, I totally get that piece of it. Trust me, as a physician, I totally get it. Physician-to-physician contact is absolutely the standard, and it absolutely optimizes that patient's stats. I just want to make sure there's not a law of unintended consequences, and I respect Delegate Sally in many situations across our many locations in the 324 localities statewide. It is the ED physicians that are actually the conduits. But I am understanding, and the CSB folks, correct me if I'm wrong, I'm understanding though that in some places that may not be the case. And the CSBs, the physicians have moved on. They're taking care of the cardiac patients and the trauma patients and the broken bones and so forth and so on. This now is going to require that should Hospital A that only has 6 psych beds, and those 6 beds are full, and someone calls and says, you know, we've got a patient that needs to come to your institution, you have a bed, and they're told no, this is now going to require 2 duties. A duty on the part of that hospital to now get that physician to call the hospital, simply be told by the same administrator, we don't need more medical information, not about MRIs, it's not about medical clearance, we get the medical piece, we simply don't have the beds. I just want to make sure that you're comfortable that that may be an unintended consequences of this.
Delegate Stoll.
Thank you, Mr. Chairman. I would speak to 2 things on that. Number one, we do have the bed registry, and so we're not spending a lot of time calling people that don't have beds. We're calling facilities that have beds and are being told no, and those are being told no for perhaps reasons that are not valid. And this forces that conversation between the doctors. And then also, one of the line items that was added and read out there is the statement, if requested by such referring physician. So if the statement is there that the referring physician wants to speak to the receiving physician, that cannot be denied. It doesn't mandate it in each circumstance.
So, Mr. Paul, so Chris, I just want to make a Delegate Sally, I'm sorry. As you know, the bed registry only unfortunately now requires a 24-hour, it only has to be updated every 24-hour when there's a change. So unfortunately, it's not the ideal setting, and we're still working through some of those issues. I just want to make sure, I'm in support of it, Delegate, I really am. I just want to make sure that we all are going into it wide open. So.
And I think the original language, that original language would have opened that door, but I do think the language that we just added tightened it up because it says if requested by a referring physician. So that means it's not going to happen every time. It's only if that emergency physician wants to speak to the inpatient physician. So I think you're right. It narrows it down. Because before, I think it could have been in every circumstance. So thank you for that. Yes.
Mr. Chairman.
Dr. Pease.
Thank you very much, Doug Stolley. I know that you're not trying to get into all the prescriptions because that will come in the regulatory process and how this is implemented. But can you tell me how these other regulations that are already on the books are enforced you're asking for a, let's see here, an on-call physician, direct verbal communication. How is that substantiated? How do you enforce this provision? What would you envision that mechanism to be?
By placing this in the code where it's located at, it sets certain standards for regulation of those facilities. And so I would imagine this is going to be enforced as would any other regulatory aspect that's put into place. It would primarily be complaint driven, so that if I'm being refused the ability to talk with a referring physician, that would generate a complaint to the Department of Behavioral Health.
And so one follow-up, would that be a complaint on that physician's record? So something regarding his particular license, or is it to the facility, or what is the respondeat superior action on that?
Mr. Chairman, I would say that this is based on the inpatient, it's a hospital requirement, not an individual physician requirement. And so it falls on the hospitals to have a protocol in place that allows that communication between the physicians. If the individual physician refused to talk or receive a patient, I believe that that would actually fall under an EMTALA violation. And we would deal with that separately.
Just an editorial comment quickly. I think all of these patients are going to be in an ER with a medical record being generated. I think. Doug Farrell.
Mr. Chairman, I move to report.
There's a second? Second. All right. There's a motion to report as amended, House Bill 1777 from Delegate Stolle. All in favor, please hold up your right hand. Okay. Got it, Becky? All right.
Thank you, Mr. Chairman.
Delegate Colatanov is not here. I think Delegate Ransom is here. Welcome, Margaret. Turn your attention, please, to 1728.
Morning, Mr. Chairman, members of the committee. House Bill, actually, I have an amendment.
Yes.
We should take that up first.
I'm sorry, ma'am.
I have an amendment on
All right.
line 13.
Members, 1728, please turn your attention to the proposed amendment from the table. Sarah, you want to report it?
Yes, we're going to add, on line 13, after insurance providers, we're adding two new categories of individuals who would be represented at the Virginia Air Medevac Committee and emergency physicians.
I think that should be a member of the Virginia.
Member of each of those respective
Yes.
stakeholder groups.
Because of the way we've got it written out, where it's including representatives of, I think we don't want to put a member in there just for the way the sentence reads. We'll put it on line 13, where we have after insurance providers, before we get into the other interested stakeholders.
And please read the specific two groups.
Yes, the line amendment will be on line 13, following insurance providers, comma, insert the Virginia Air Medevac Committee,
And
comma, emergency physicians, comma.
what is that committee a part of?
That committee, they're actually here today. They can speak and explain. They're a group that, I guess, will fly out and pick up folks.
So they're not a part of government or anywhere else. They're there.
They're a segment of the Virginia Department of Health.
Okay, so that committee
this idea, I'm bringing this bill because I was contacted by a constituent who actually, he had a stroke and had medevac not shown up, he probably would not be alive today. But when he came back home, he also had a $38,000 medevac bill. And his insurance company did not cover that. And, he just went through a lot of different things. I've gone to his insurance company, I've gone to the medevac company, I've gone to the hospital just to try to work this out. And I've talked to all of the stakeholders, and this was the agreement that we came upon. Everybody needs to come to the table and try to figure out what is going on. Certainly in the rural area, we need them, but we need to figure out the best protocol of when do you call them.
Okay, I appreciate that very much, and I will say that capability is incredibly important in your part of the world and a lot of parts of the world, so it's worth studying. All right, any folks in the public for or against this amended? Well, come on.
Good morning, my name is Kelly Keener, and I'm a representative of PHI Air Medical. We strongly supported the communication and dialogue regarding the utilization and dispatch of air medical services. Of concern for us was that specifically air medical providers were not listed as a stakeholder in the working group. We've discussed the amendment with the delegate, and it seems that has been addressed, and I have provided some written testimony to share with the committee as well. Thank you.
Thank you very much.
Mr. Chairman, Eldon James on behalf of Fauquier County and Fauquier County Board of Supervisors support this study very much. Thank you.
All right. Yes.
Mr. Chairman, Ed Rhodes represents Virginia Fire Chiefs and the Virginia Association of Volunteer Rescue Squads, and we also support this measure. We feel it's timely at this point.
Thank you, sir. Any other comments?
Mr. Chair,
Doug Farrell.
I know that Scott and Cal will nod, because I know in the workers' comp group, just on the workers' comp side, they had trouble dealing with how to figure the airbag stuff out. So anything we can do to get our arms around it would be good. So I move to report the bill as amended.
You're technically not supposed to speak to stuff before you make that motion.
Technically, I apologize, Mr. Chairman.
All right, motion to report as amended is before the second. All in favor? All in favor, please raise your right hand. Okay, thanks. Mark, are you in the middle of a meeting?
No.
Oh, let's get Roxanne. Roxanne, why don't you come on and do yours, and then we'll get Delegate Cole up for you.
Thank you, Mr. Chairman and members of the committee. This is House Bill 1625. What it has to do with is just the food truck industry. It's a growing industry. There aren't a lot of regs and laws kind of around food trucks, and this is very specific to them. You can see in the bill what it does is it gives us a definition of what a mobile food unit is, and then what we're asking for is that the department will issue some form of license sticker so that it just shows that they've been it will just show that they have been have a license. Because what happens is they go to these events and they'll show up at an event, a 2-day event here, a 2-day event there, and then someone through the health department will come through and say, oh, are you licensed? And this is just to give them some kind of recognition, stick it on the truck, then that way they're not going to be asked to get the paperwork and out for every time that they would attend like a 2-day event.
Mr. Chairman.
Are you finished your presentation?
Yes, that's fine.
Just to be clear, the industry wants this bill,
Correct.
wants to be regulated.
Correct.
Well, I think they want to have the recognition at events that they've already been.
Yes, and they already have to have that, but if they don't have it on display, then they have to stop their whatever they're doing and go find it and put it in, and stop their whatever their services, whether it be ice cream or sandwiches or whatever that food truck happens to be doing.
Any other community questions? Delegate Garrett.
Mr. Chairman, it's a small point. Delegate, I supported your display the kebab is very important. So you mentioned these are for food trucks. What about for food trailers? I have a trailer in my district that they're only there during the summer. It's just ice cream. It's way, way overpriced ice cream, but it's all, and it's basically covered. The wheels are covered. They put it in there, and it's, you know, it stays there for about 6 months or something like that. Is your intent that that would be covered as well? And I guess my question is, if in fact it is covered, great. If not, do you need some sort of a, so I'd ask counsel. I see some nodding of her. Scott, your usual over-analytical wrong self.
If you look at the definition we have of a mobile food unit, that is a restaurant or other licensed food establishment that is mounted on wheels and readily movable from place to place. That's paralleling a lot of what we see in the existing Department of Health regulations, and they clarify in their regulations already that when we are looking at a mobile food unit, that includes not just trucks, but also push carts, trailers, and
Perfect.
vans.
Thank you, counsel.
Thank you, council.
Mr. Chair, I know you really hate having questions, but I'm just kidding. I'm just I just want to make sure I get as simple as this is. This is basically saying, hey, they all have to do this anyway, just give them a sticker so people can see it. That's all we're doing?
That's all we're doing.
Cool.
Any public comment? Yes, sir, come up.
Thank you for letting me speak over here today. I came to Delegate Robinson for this specific thing because we go to many events in many different jurisdictions that we're licensed for. And you'll show up one day and they'll say, oh, we need to do an inspection. Then the next day you got to do an inspection. Then the next day you got to do an inspection. And it just gets to be overbearing. So if we had the sticker on the outside, the inspector come out, they've been inspected, they're good to go, they can move on.
Good report. Okay. Whoa, somebody beat you to it, Peter. One quick question of the patron, the health department, there's no problems from the agencies, everybody?
No.
This is a good housekeeping seal of approval. All right, there's a motion to report without amendments. All right, everybody in favor of reporting 1625, please raise your right hand. Okay, thank you. Dr. Cole, welcome.
Okay, I have House Bill 1424.
All right.
And this was requested by a doctor in my district who, and what it would do is require that on a prescription that you state the purpose of the prescription and also on the label of the medicine jar whenever it's filled. And he felt like that this would help the patient and also any caregivers to know the purpose for the prescription. Sometimes he's had experience with especially senior citizens who may try to ration their prescriptions and stuff, and they don't, if they have multiple prescriptions, they may not know which ones they really, really should be taking and which ones, you know, if they skip it once or twice, is it going to cause a problem? And so he thought that this would help clarify that and also help potentially reduce emergency room visits and things like that.
All right, thank you very much, Delegate Cole. You heard the bill. Any members have any questions?
Chairman.
Delegate Ed.
Thank you, Mr. Chairman. You would wonder, what happens if the doctor that prescribes doesn't, on the prescription, put that kind of instruction and you put that kind of a burden on a pharmacist? Does that not then put a pharmacist in a position of...
Come through. Okay. Delegate Cole.
It would require the doctor to do that. So if he doesn't do that, he's not doing his job.
Mr. Chairman.
Delegate Gary.
And I apologize, I was in a bit of a sidebar. So did I understand you to just say, if I as a physician write a prescription for antibiotics and I don't write on that prescription it is for the calf infection, I would not be doing my job?
That's correct. If this bill were to pass and become law, you would be in violation of the law.
Okay, any public comment?
Morning, Mr. Chairman. Scott Johnson, General Counsel for the Medical Society. We are opposed to the legislation. I shared that position with Delegate Cole early in the session. If this bill is worded, it would apply to every prescription, whether it's inpatient, outpatient, all the way across the board. And certainly physicians want patients to
know what their medicine's for, but we prefer them do it by talking to them as opposed to putting something on a prescription pad. So the burden this would cause would be mighty, and we would ask you not go forward with the bill.
Mr. Chairman,
Jared?
question for Mr. Johnson. So, Scott, if, does the pharmacist have a HIPAA exclusion such that that individual can know my medical history and why I'm being treated for certain conditions?
I can't quote you one specifically, but I believe so. I may ask my friend James to phone a friend in to see if he knows, since he represents a pharmacist, if I may, Mr. Chairman, but I don't think that's an issue, but I'll defer to him.
Mr. Pickle?
Mr. Chairman, members of the committee, I don't know that it would be a violation of HIPAA. Generally, pharmacists might not know what the specific condition. As you know, medicines can treat various conditions. I will tell you, just in clarification, this can already be done at the pharmacy at the request of the patient.
Thank you. Any other?
Delegate,
Delegate Peace.
For Mr. Johnson, before you walk away, just a quick question. I'm certainly not a doctor, but my understanding is that you can get a prescription for medication for something that's considered off-label.
Yes, sir.
Would this bill introduce a chilling effect to that practice, or otherwise put that prescribing doctor in any kind of precarious situation, or raise any questions of liability with respect to, you know, for example, I take Humira for psoriatic arthritis, but I know that it's also used for people with Crohn's disease. I'm not sure if that's on indication, but it's being prescribed.
Correct. And Mr. Chairman, I would say that certainly a physician would have thoughts in their mind of a plaintiff's attorney picking up a label off of a drug box saying, here are the indicated uses, and tell me why you decided to go off-label with a prescription, even though you thought it's best for your patient.
All right, Mr. Jamerson? Anybody else piling on?
Mr. Chairman, good morning. Hunter Jamerson for Epic Pharmacies. I thought it would be helpful to illuminate the committee. Virginia law presently requires that a tripartite relationship between the pharmacist, the physician, and the patient be in place. And as part of that tripartite relationship, the pharmacist must understand the therapeutic necessity of the medication. So if there's any doubt in the pharmacist's mind what the diagnosis would be, the pharmacist is certainly able to presently avail themselves of the physician now in order to accomplish that relationship. So for that reason, we think the bill is unnecessary.
Thank you. Anybody else?
Mr. Chairman, members of the committee, Jody Roth on behalf of Virginia Association of Chain Drugstores, and we also oppose this legislation for all the reasons previously stated. Thank you.
Any other public comment? Any other committee questions? Delegate Cole, why don't you?
Well, I would just like to point out that the goal of the legislation is to make sure that the patient is informed of the purpose of the medicine, and not necessarily the pharmacist, or hopefully the doctor already knows why he's prescribing it. And that was the intent of the requester, is to make sure that the patient understands the purpose of the medicine they've been prescribed.
Thank you. I think your bill has certainly generated interest and accomplished dialogue on this issue.
Mr. Chair,
Delegate,
I move to gently lay it on the table.
any discussion? That's not. All right. All in favor, please say aye. Aye. All opposed? Thank you, Mark. Last, I think, Becky, our last piece is 1798. 1798 is mine, so I'm going to turn it over.
Delegate O'Bannon.
Thank you. House Bill 1798 is a very simple bill. It has to do with transplants. There is current federal regulation that says if a patient is an HIV positive patient and needs an organ, that organ can be obtained from an HIV positive donor. And so HIV is now not a terminal illness, it's a lifelong condition with which people live. Some of those patients get organ failure. All this does is simply makes it clear that as long as both parties know what's going on, that those organs can be harvested and reused. I hope that answers your question.
Are there any questions from members of the committee? Is there anyone in the public who would like to speak for or against this legislation? Hearing none, there's a motion to recommend reporting House Bill 1798 properly second. Any discussion on the motion? Hearing none, all those in favor indicate by saying aye. Aye. Raise your right hand. Thank you.
Thank you, Chris. All right, I think that completes the subcommittee's business. I appreciate everybody's attention today and attendance, and we may well have something Monday night. We have 17 bills remaining in our sub. The full committee has over 100, so we will plan to work Monday at 5 and do the best we can. Thank you all. We're adjourned.
We were wrong.